Dr. Fuentes-Afflick has been a UCSF faculty member since 1993, and she's professor and vice chair of pediatrics and chief of pediatrics at the Zuckerberg San Francisco General Hospital. She also holds the role of vice dean for academic affairs in the School of Medicine. In her work as a pediatrician and epidemiologist, Dr. Fuentes-Afflick has conducted research studies focused on issues of acculturation, immigrant health, and health disparities. And she also is interested in the portrayal of body mass images in Latino television media, principally in telenovelas. In her role as Vice Dean for Academic Affairs and Faculty Development for the School of Medicine, she's responsible for overseeing all the academic affairs in the School of Medicine, all the way from recruitment to development to advancement of a diversified academic workforce of the highest caliber. She's also responsible for overseeing innovative programs for faculty orientation, career development, and leadership training. She also completed her fellowship in health policy at UCSF and MPH in epidemiology from UC Berkeley. As Mary mentioned, she's served in several important national leadership roles, including president of the Society for Pediatric Research, president of the American Pediatric Society, and service on the council of the National Institute for Child Health and Development. She also was elected to the National Academy of Medicine in 2010. So with that, I give you Dr. Fuentes-Afflick.
Thank you. Good morning, everyone. Thank you so much, Dr. Floyd, for your introduction, Dr. Leonard for the invitation. Thank you. I'm delighted to have this opportunity to share some work with you in the area of health disparities. I have no conflicts to disclose to you, and I have two objectives for my presentation. First, to summarize my scholarly work in health disparities and present to you some research and policy frameworks relevant to this area. And second, to highlight departmental, institutional, and organizational approaches to advancing diversity, equity, and inclusion. So my roots are in Chile, and I grew up in the state of Michigan. Just want to give you some context. I went to school at the University of Michigan and completed my undergraduate and medical education in an integrated program called Interflex that was intended to test the theory that an education that integrated arts, social sciences, and ethics would produce a more caring doctor. Our most famous alum is probably Sanjay Gupta. After I completed medical school, I decided I wanted to leave the Midwest and matched to UCSF, where, as Dr. Floyd mentioned, I have been since I arrived as an intern. When I came to UCSF, we were a two-institution hospital, the UCSF and what we used to call just San Francisco General Hospital. And I joined an incredible class. You can see I'm in the front row, third from the left. You will notice Dr. Abraham Rudolph of Rudolph's Pediatrics. Let's see, I don't know if you can see my pointer, but he's the gentleman in the suit coat in the front. And on the far right is our now chancellor, Sam Hawgood, who at the time was a regular neonatology faculty member. So I was lucky to train at UCSF, a very exciting place for those of you who have experienced it. Followed, as Dr. Floyd mentioned, by training in epidemiology at Berkeley, fellowship in health policy back at UCSF. And then I joined the faculty. I've always been based at the General in 1993 and have been fortunate to have many colleagues, wonderful colleagues and opportunities there. So my career I would divide into two phases. In the first phase, which was 93 to 2008, my primary focus was on research, and I'm going to share with you some of those findings. Since 2009, when I became Chief of Pediatrics at the General and 3 years later, Vice Dean, I have focused largely on administrative leadership. I mentioned 2009, I was appointed Chief of Pediatrics, where I work with about 40 people who are absolutely amazing and committed to the work that we do at the General. And since 2012, in my academic affairs leadership role, I was appointed by now Chancellor Hawgood. He was Dean at the time, now work closely with Dean Talmadge King on the bottom left, and my two colleagues, Renee Binder and Paul Garcia, as Associate Deans. So back to the beginning of the research career, I've always been interested in pregnancy outcomes. How do we predict who will have a favorable pregnancy outcome or who is at risk for an unfavorable outcome. And this slide is a familiar one where we recognize what are risk factors for adverse outcomes. We know ethnicity is important, but we also know that age, education, socioeconomic status, marital status, interpregnancy interval, body mass, all of these factors are important predictors, in this case of prematurity, but we could substitute low birth weight or infant mortality because they share many common risk factors. But what I experienced was a form of cognitive dissonance because in my work at the General, also at UCSF, but primarily my work at the General, where about 70% of our maternal and pediatric patients are Latino, I was not seeing this translation of risk factors into adverse outcomes. I was seeing plenty of high-risk women or caring for them as mothers of my patients, but the babies that they delivered and the children I was caring for were not experiencing, for the most part, these adverse outcomes. So what I was calling cognitive dissonance, others have called a paradox, where there's a mismatch between expected and observed outcomes. And this was originally reported in the 1980s based on data from the 1950s and 60s. And the first real study that put this concept on the map, as it were, was a study of Latinos in the Southwest, where researchers noticed that the Latino population had very low rates of use of mental health services, despite the risk factors. And so they coined the term an epidemiologic paradox. In the area of perinatal health, the same finding was documented looking at neonatal mortality in Texas during the decade of the 1970s. Now, first, I would note that overall, since the 1970s, we have experienced incredible improvements in neonatal and infant mortality. The y-axis on this slide is percent, and we don't talk as much about percents anymore for mortality. But what I want to show you is that over that decade of the 1970s, African-American women have consistently had higher rates of neonatal mortality. And the paradox is that the pink line for white women and the blue line for Latinas are virtually overlapping. That is the paradox right there. Some investigators thought that maybe looking at the whole state of Texas was not as accurate. Maybe there was opportunity for data errors. And so they undertook a study of infant mortality in Harris County, Texas, which is where Houston is based, farther from the border, perhaps less subject to cross-border data inaccuracies. And when they looked at the same three ethnic groups, this is 1974 to 75, they found the same thing, that whether for neonatal on the left or post-neonatal on the right, the rates for the Latina and white women were virtually the same, providing further support for the paradox. The original interpretations were that there was underreporting of infant death, that there were errors in the data sets, or that these models, the models that predict outcomes, just don't work for Latinos. So that was the interpretation that was applied in the beginning. Well, we know that there's a difference between differences in outcomes and disparities in outcomes. So I would like to now focus on the concept of disparities. Beginning with the definition, the NIH defines disparities as differences in the incidence, prevalence, mortality, and burden of diseases and other adverse conditions that exist among specific subgroups. Ana Diaz-Ru, one of the great epidemiologists of our time, defines disparities as systematic, plausibly avoidable health differences that adversely affect socially disadvantaged groups. So puts a finer point on the application of the concept of disparities. My particular interest really is in racial ethnic disparities, but there are many other disparities that one could consider, including disparities by national origin, rural-urban residence, socioeconomic status, sexual orientation, disability status. But whichever form of disparity is of interest, you might wonder, why are these important? Why is it important for us to consider them and to address them? Well, one is the social context in which we live, that if there are disparities, particularly avoidable differences in outcomes, that should matter to all of us. From a scientific perspective, understanding why they exist and how we can mitigate them is a scientifically compelling issue, I would say. As a society, I believe we have a commitment to reducing inequities and disparities, so there's a moral component. And if you only care about strategic goals like market placement or marketing your own services, then elimination or mitigation of disparities is important. So you can come at it from a number of different perspectives. Wong and Leviste, among others, have said that disparities are a threat to healthcare organizations because increasingly insurers looking at payments are factoring in inequities and disparities. So again, from a number of perspectives, the mitigation of disparities is important. So now I'd like to share with you some of my own work in this area. And as I say, I've focused largely on perinatal epidemiology. So presenting again to you, we have known about ethnic disparities in infant mortality basically as long as we have collected data. This slide depicts the improvements in infant mortality since the 1940s, as well as the gap between African-American women and, in this case, white women. Everyone else is depicted as all races in there. But you see the gap over time, despite the improvements in infant mortality. And these patterns are still continuing. This is not an artifact of the 1940s or 50s. You can see that basically we are continuing to see improvements, but the same gap in mortality rates. In my own work, we focused a lot on California data. We know that we are a big state, and we represent about 15% of all births in California, but pretty much our experience mirrors the country's experience. And when we undertook an analysis of California data from the mid-90s, on the far left, you will note that we did not find a statistically significant difference in the risk of neonatal mortality between African-American, Latina, and white women. But when we looked at post-neonatal, which is days 28 through 364 days of life, we found that African-American babies were significantly more likely to die than white babies, and Latino babies were significantly less likely to die than white babies. So consistent with what we found, and after adjusting for a whole number of risk factors. In another study, a colleague and I looked at the published experience in low birth weight, and roughly time is on the x-axis. And what we analyzed was the reported incidence of low birth weight in a number of populations. This study summarized national, regional, state level populations. And pretty much no matter how you look at the finding, the rate of low birth weight is consistently similar for Latina and white women and consistently higher for African-American women, which is essentially the paradox. And again, this is not an isolated phenomenon in California or from the 1970s. These are more recent data from the US showing both low birth weight in blue, prematurity in orange, that we have these persistent patterns of difference that continue to be important. So the paradox of perinatal outcomes among Latina women is true for infant mortality, for low birth weight, and prematurity. But when you talk about Latina women in particular, but other ethnic women as well, pretty soon you bump up against the concept of acculturation. I like this definition. It defines acculturation as a process by which immigrants adopt the attitudes, values, customs, beliefs, and behaviors of a new culture. And acculturation, we could hypothesize, might influence health outcomes in a number of directions. You might hypothesize that acculturation is not associated with health outcomes, that there would be no difference. You might hypothesize that acculturation increases the risk of adverse health outcomes, or that acculturation could decrease the risk of adverse outcomes. In some ways, it depends on both what you define as acculturation and who you're thinking of in your mind. So if we think of this image of farm workers, we may say, well, that is a disadvantaged population. So if they come here to this country and maybe have more access to care or better access to other services, we might expect that as they acculturate or adapt to our culture, then perhaps their outcomes would increase or would be more favorable. If you think of immigrants as being an advantaged population, coming perhaps with educational or other social resources that may be greater than what we have here on average, then you might expect that acculturation to our norms would be disadvantageous for health outcomes. So it's plausible to hypothesize that the relationship between acculturation and health could go in a number of directions. Well, if we define acculturation by birthplace, which is a very common measure, partially because birthplace is commonly reported, then for childbearing women in particular, it's important to understand from the outset that there's wide variation. As depicted on this slide, in the whole US, more than 90% of childbearing white women are born in the US. A little more than 80% of childbearing Black women are born in the US. But for Latina women, it's not quite 60%. And for Asian women, it's not quite 20%. So if birthplace matters as a measure of acculturation, you would anticipate that there would be variation by ethnicity. What we have analyzed is the risk of several outcomes. I'm showing you here the risk of infant mortality among Latina women, and we categorized acculturation by birthplace. And what we found was that relative to US-born Latinas, foreign-born women, in the unadjusted models, the adjusted odds were higher. So foreign-born Latina women were 8% more likely to have an infant death than their US-born counterparts. But after we adjusted for a large number of demographic, reproductive, health service risk factors reported on the birth certificate, we found that foreign-born Latinas were 12% less likely to have their infant die, independent of anything else. And in this slide, again, you can see that the infant mortality rate that we are showing is in many ways reproduced when we look at the national data, that we are finding differences, not just in California, but also in the national population. We've also studied the risk of prematurity by birthplace. And in this study, we have Latina and white women combined. And when we, in this data set, again, after we adjusted for a number of risk factors, we found that the adjusted odds of both very preterm and moderately preterm infants were 8 to 18% lower than their US-born counterparts, which is quite a substantial decrease. And moderately low birth weight, here we analyzed different populations, and we only found the birthplace advantage for Latina women in our sample, 9% lower risk of moderately low birth weight. And we did not find a statistically significant difference between foreign and US-born Asian, Black, or white women. Similarly, for very low birth weight and moderately low birth weight, again, this study focuses only on Latina women, but we found 9% lower risk of moderately low birth weight for Latina women relative to their US-born counterparts. So if you accept that there is a paradox and that we don't quite understand it, for Asian and Black women, the perinatal advantage for foreign-born women has been documented in some, but not all studies. Whereas for Latina women, virtually in every study, there is a documented perinatal advantage for foreign-born women. I want to say a few words about immigration status because birthplace is one measure of acculturation. As I mentioned, it's very commonly analyzed because it is a reported variable. If you go beyond birthplace to measures such as the number of years in the US, the age at immigration, you have to interview people, and that's much more time consuming. In one study, we analyzed directly the impact of immigration status, and we recruited a large cohort of women We asked them a lot of questions. It was about a 1-hour interview, and the final portion of our interview focused on immigration status. And in this study, women in the Bay Area, slightly more than half of them told us that they were undocumented. About 18% told us that they were citizens, another quarter told us they were documented, and again, a little more than half told us that they were undocumented. And when we analyzed the impact of immigration status, what we found was that there was a difference by immigration status, not in the use of preventive health services, but in the use of dental care services. And we found that both undocumented as well as documented women were less likely to report receipt of dental care services than their citizen counterparts. This is, I would say, more of a suggestive study than a definitive study, but demonstrates that documentation status or immigration status is an important measure and deserves further study. Lest you think this is just an American phenomenon, this study shows the impact of the paradox within Germany. Germany, as you know, has a different immigration status or different immigration history, and they have many immigrants from Turkey. What these investigators reported was that looking at prematurity, women who reported a higher acculturation index in their study were more likely to deliver premature infants. And women who were born in Turkey, disadvantaged in many ways in the German context, were less likely to have premature infants than women born in Germany, independent of other factors. So this is not solely an American phenomenon. But even with all of this, we have residual questions. Why does the relationship between birthplace and perinatal outcomes vary by ethnicity? Why do immigrant Latina women have better perinatal outcomes than their US-born counterparts? And why do immigrant Latina and US-born white women have similar outcomes? These are all different aspects of paradoxes, but pretty much unexplained. And why do we call the paradox a paradox? Dr. Jane Delgado wrote a very interesting commentary in the New England Journal, and what she says is, though the accumulation of new evidence may warrant a paradigm shift, the human tendency is to hold on to our familiar conceptual models, even when new data encourage us to develop alternative ones. And I think that's true not only in perinatal epidemiology, but in many fields. Because part of our traditional thinking is that there's one model that we apply across population groups. And I hope I've convinced you that that has significant limitations. Our conceptual model for health, we apply to health disparities, has focused on behavioral factors, demographic factors, health service, and reproductive factors. And we've developed policy approaches based on these conceptual models. So for behavioral factors, we have created policies to discourage the use of tobacco during pregnancy, discourage the use of alcohol during pregnancy and illicit drugs. In the category of demographic factors, we have been very successful in reducing adolescent childbearing. In health services, we have expanded access to Medicaid. We encourage early and continuous use of prenatal care. And in the reproductive factor category, we've tried to optimize inter-pregnancy interval. So this is how the model translates into policies, and in many ways, we have been successful. But our standard conceptual models still do not explain why do African-American women have a disproportionately and persistently elevated risk of adverse outcomes? Why do Latina women have lower risk? And why, in general, do immigrant women have lower risk? I think there are factors that have not been fully considered or tested. Acculturation status, I already mentioned, we've emphasized birthplace, but the whole phenomenon of acculturation and its effect on health outcomes has not been well studied. We are just now, as a society, beginning to understand and appreciate racism. We talk about it now more openly, but we still, as health professionals, have not really studied how does racism affect health? How does classism affect health? How does anti-immigrant discrimination affect health? And as physicians, we are trained in risk factors, but what about positive factors? What about factors that may promote health, and how can we support those? Things like resilience, social support. What I call relativity is immigrants, many of us have immigrant backgrounds. We know that an immigrant has a relative sense of poverty, a relative sense of what I can provide for my family here versus what I could provide in my country of origin. That may be a mindset that translates into health outcomes, but there are many factors that need to be considered and new directions we need to take. I'm going to summarize for you very quickly some of the new ideas that I hope some of you will be encouraged to pursue. One is called the fundamental cause model. And this is a way of thinking that highlights the importance of structural factors related to our social and economic organization, and consider these as fundamental causes of health disparities. There's also the pathways model that talks about how do we understand, analyze, and then address the mediating pathways between factors as risk factors for outcomes. An interaction model discusses the interaction between variables, not considering them individually, but understanding that they may interact. And of course, this lends itself very easily to environment and gene interactions, but there are other forms of interactions as well. I want to put forward some other ideas. We need longitudinal studies. They're cumbersome, they're time consuming, they're expensive, but we need to understand trajectories over time. And we need to understand the life course effect of several, I would say, unique factors. What about demographic factors? How do medical experiences play out over the lifetime? Yesterday, I had the opportunity of dinner with Stephanie, I don't know your last name, medical oncologist, and she was talking about the long-term impact of oncology problems. That's an example of a life course approach. Obstetric and reproductive factors and acculturation. How does it change over the life course, and what are their critical periods? We also need to think about stress. How does it affect us? We talk about it all the time in our common parlance, but I would say we don't really understand it. And what about discrimination and anti-racism or racism? How does that impact outcomes, and what can we do about it? What is our role as health professionals and health system leaders? There is evidence around some measures of racism, and this slide shows a study looking at isolation and clustering. So isolation may be a risk factor, and you can see that the risk of prematurity increased as the isolation measure increased. Clustering refers to living basically in a same ethnic community, thinking that that may be a supportive structure. And I would say there's some, you can see that the pattern is not as consistent or as strong, but there is some evidence that clustering may be protective. So I agree with Dr. Delgado in her statement that we must be willing to step back and look critically at what we know, reflect on the adequacy of current models, and pursue alternative models. So now I'd like to highlight broader structures and what we can do. Beginning with departments, I know that Dr. Leonard in her leadership has a number of initiatives. I want to share with you a little bit of our experience at UCSF. We have a vice chair for diversity, Dr. Alma Martinez. We have formed a number of diversity committees that include faculty, residents, and staff, and bringing us together is a very helpful structure. We have revamped our intern selection process and been very successful in recruiting a more diverse cohort of residents. Under Dr. Talmadge King's leadership, we have also implemented a number of initiatives, including the Differences Matter initiative. I hope that some of you will take the time to look this up later. It has multiple areas, including leadership, faculty, residents, and staff, education, the clinical environment, and research. We have a faculty and a staff lead for each area, an executive sponsor. There are resources invested. We are now in our 7th year of this program, and it has been quite successful. I want to tell you a little bit about committee composition. It's one of the things I'm proud of in my Dean's Office leadership role. When I came into the Dean's Office in 2012, I signed a lot of search committee forms, and I noticed there was a box where the person completing the form had to attest that there was at least one woman or underrepresented person serving on the committee. Well, one, I think we can all agree, is a token. And so by the end of 2013, I had worked with my colleagues in the schools of dentistry, nursing, and pharmacy, and we increased that expectation to 25%. So we said then 25% of all committees must consist of women and underrepresented people. So after a couple of years of that, I felt that we could do better. But my colleagues in the other schools were not quite ready to go to 50%, which was my recommendation. But thankfully, Dean King was supportive. And so we presented this to the chairs in the School of Medicine. And in 2017, we set an expectation that all committees comprised within the medical school had to consist of 50% women or underrepresented people. It's hard really to know how policy changes like that within a school actually play out. But I would say that this is suggestive that it has been an effective strategy. So in 2012, our policy was one woman or underrepresented person. In 2013, we had the expectation of 25%. And by 2017, we had rolled out the 50% rule. And what I'm showing you here is a substantial increase in the proportion of women who held endowed chairs over that period of time. I can't conclusively say that it was cause and effect, but I hope you agree that it is at least suggestive and would suggest that although there are many things that are out of our control and we often feel a little helpless to influence, I hope that you will consider committee composition as one of the strategies that you can use to impact diversity within your own school. As noted in the introduction, I've been very involved in a number of organizations, including DEI efforts. Within the American Pediatric Society, Dr. Bruder Stapleton, who at the time was chair of pediatrics at the University of Washington, asked me to form first a task force that was created into a committee on diversity and inclusion. We were founded in 2012. And our goals were to promote diversity and inclusion both within the American Pediatric Society and to promote diversity and inclusion in academic pediatrics. As a committee, we created a members database because until that time, we couldn't have characterized the diversity of our members. We created scientific programming at the PAS meeting, and we served as a liaison to other societies and organizations. The scientific presentations that we hosted, I hope some of you participated in them, included unconscious bias and diversity in pediatrics. We focused on disparities and unconscious bias in the clinical setting. We had one called Reaching for the Tipping Point for Equity and Inclusion in Academic Pediatrics. Another entitled The Elephant in Our Room, trying to bring topics that are difficult to discuss into the open. And in 2018, a session on implicit bias. So we've tried to elevate the profile of these topics and begin conversations within our academic pediatric community. I've been honored for many years to serve on the National Advisory Committee for the RAPID program, that stands for Research and Academic Pediatrics Initiative on Diversity, co-led by your own Dr. Fernando Mendoza and Glenn Flores, now at the University of Miami. This has been a program, basically a junior faculty mentoring program. It's how I met Dr. Floyd right before the pandemic. It's a wonderful, very hands-on mentoring experience for underrepresented faculty to get mentorship and support as they begin their career in academic pediatrics. We've published a paper that summarizes what we consider our keys to success in academic pediatrics, and I hope these messages resonate with you. They include having multiple mentors who are invested in you, focusing on publications. We know that is the coin of our realm and we cannot overlook that. We think it's important to be tenaciously persistent. It's a key skill in our area. Be open to non-traditional funding sources, balance your committee work with your regular or day job, and ask for resources when it is appropriate. I want to end with some reflections, give you what I hope are some pearls or lessons that I have learned over my academic career and the way that I've tried to, as I said, apply a disparities lens to my own career, but recognize that none of us does this independently. I want to be very thankful to the chairs who supported me at critical points in my career, beginning with Larry Shapiro on the left, who was chair when I came into my faculty appointment. In the middle is Sam Hoggood, who was our chair when he appointed me into my leadership roles, both in pediatrics and in the dean's office, and now serves as our chancellor. And Dr. Donna Ferrero, who was a role model for me as a woman in leadership and has taught me a lot about what that means. I also want to say that there can be many key people, and I want to tell you about a few of them because some of them you would not have anticipated to be important. On the far left is Dr. Robert Kelch, who was chair of pediatrics at Michigan when I was a medical student. And he met with every medical student who was going into pediatrics. And when he knew that I wanted to leave the Midwest, he recommended that I consider UCSF because he had completed his endocrinology fellowship at UCSF. And he said it was a wonderful place and I think you could be happy there. And he was definitely right. Second from the left is Dr. Maury Shamblin, who's an adult endocrinologist. His area is in metabolism, primarily around HIV. And Maury was an important person because I wanted to create a cohort of Latina women and follow them, look at the influence of acculturation. And when I met with Maury to explain my idea, he said, he was the leader of the General Clinical Research Center at the General, where basically they did metabolic studies and tobacco metabolism studies. And he said, well, we've never done anything like that, but I don't see why not. So he checked with the NIH officer who said that would be fine. And I received an award that is essentially the precursor of the K-23. And that was a really important milestone for me. Dr. Sam Hoggood, who I already told you, appointed me into my leadership roles and who's played a pivotal role in my career development. And on the far right, Dr. Victor Zhao, who has encouraged me in my leadership roles within the National Academy of Medicine. So my lesson is you never quite know who's going to help you and be open to possibilities. I've already highlighted the importance of mentors. I hope you all have mentors, but I want to tell you about mine because some of them you wouldn't have expected. Upper left is Dr. Eliseo Perez-Table, who's now the director of the National Institute for Minority Health and Health Disparities. At the time, Eliseo was division chief of general internal medicine at UCSF. And he, along with Dr. Jean Washington, depicted in the middle, were creating a center. We would now call it a health disparity center. We called it minority health at the time. But they were both very influential research mentors and career mentors to me. On the right is Dr. Jay Tureen, a pediatric infectious disease, now professor emeritus, who has always kept me on track. So he nominated me for SPR, for APS, and he kept me on track in pediatrics because most of my mentorship was outside of our department. I've also had very rich mentoring relationships with colleagues outside of UCSF. Depicted on the slide upper left, Dr. Nancy Andrews, who was at Harvard, then at Duke. Lower left, Dr. Sharonda Vaskar, who's chair of pediatrics at UCLA. Upper right, Dr. Ora Peskovitz, who I've known through SPR and APS and has been a general career mentor. And lower right, Dr. Sue Desmond-Hellman, who was our chancellor and with whom I had an opportunity to work in an academic senate leadership role. I've also had peer mentors, friends and colleagues who have helped me in pediatrics and outside of pediatrics. So I want to say to all of you who are junior faculty or trainees that mentorship comes in many forms and in many sources. But I want to say a few words about committee service. Apart from the committee composition I presented to you, I think it's really important. We do much of our work through committee service. And unless you're in the room where it happens, it's hard to have a voice. So I have found committee service to be a very rewarding place to have an impact on my institutions. I told you about Dr. Maury Shamblin, who offered me the opportunity in the General Clinical Research Center. So you won't be surprised to know that when he asked me to lead the advisory committee, I was not in a position to decline the request. But I learned a lot about how to respectfully address thorny issues, how to interact with people who were a lot more senior and a lot more accomplished than I. And so I learned a lot through that advisory committee service. And I had the opportunity to be chair of our academic senate at UCSF, which gave me a perspective on the university as a whole. And in that role, that was why I interacted with our chancellor, Sue Desmond-Hellmann. And she also taught me a lot about what it means to be a woman in a leadership position. As Dr. Floyd mentioned, I've served on the council of the National Institute for Child Health and Human Development. That you could say, well, that's a committee, that's a lot of time. That's true, but I learned really how NIH works, met some incredible people, and really had a wonderful experience. And I also have served in a leadership role for the Society for Pediatric Research. I hope David is on the line. This shows our council picture. We all look very serious in this picture, and I don't know why, because we were in Hawaii and we were having a really fun time. But the Society for Pediatric Research showed me how, when we come together as pediatric professionals, we can have a powerful voice on important issues. And I want to just tell you one story about how people come in and out of your life. The year that I was president of Society for Pediatric Research, the gentleman in the middle is George Lister, who was president of APS at that time, and on the far left, Dr. Tina Chang, who's now chair at Cincinnati Children's. So she was president of APA, George was president of APS, I was president of SPR, and that gave us an opportunity to interact. But Tina and I go way back because we were interns together, we were chief residents together. This picture shows us at an academy conference. So you never know how your fellow residents, your fellow fellows, your early colleagues will come in and out of your life over time, and they're incredibly powerful relationships. Several years ago, I was honored to serve as president of the American Pediatric Society. And again, these are wonderful opportunities to have a role and a voice in our profession. And this was taken at my induction into the National Academy of Medicine. You'll notice the shocked look on my face where I can't quite believe that this has really happened. But the National Academy has been an incredible opportunity for me to contribute and to represent not only a pediatric perspective, but to have a voice in the issues of our time. But we know that work is not all of what we do, that we try to balance our work and our home. And I want to express my gratitude to my husband, Peter, my two sons, Andres and Tomas, for their support, because we know that they help us free up our time to invest in some of these other entities. So in closing, what I hope I have shown you as perhaps not a straight path, but it may look like a well-illuminated path that I have followed over my career. And I can tell the story in that way. But if I'm honest, there are many times when I have felt like I was blindfolded and really hoping that I didn't stumble with the next step. So I hope that gives some hope or encouragement to those of you who feel like you're not sure what the next step will be, but I hope that you will continue to pursue your passion and your interests. And I'm honored to serve in this Crowley lectureship. I had the opportunity not to work with him, but to read about him. And there were two lines in a summary of his contributions that resonated with me and that I hope have an overlap between he and I. He was described as a rare physician who enjoyed medical administration. And I will say that I love administrative work. I think it is a very powerful way to have a voice and have an impact on what we do. So I think I share that with Dr. Crowley. And it's always hard to know how one is perceived by one's colleagues. But I hope I share with Dr. Crowley the ability to keep one's cool and make good judgments. So the points that I hope you will take away is that the goal of eliminating health disparities requires new conceptual models, new interventions, coupled with a commitment from each of us as individuals and as a group to eliminate health disparities. And I encourage you to define your own path to action, whether that's through your clinical work, through your scholarship, through your institutional collaborations. There are many ways that we can achieve this goal. And finally, in closing, the great Nelson Mandela, who said it always seems impossible until it's done. And I hope that we will work together to achieve that goal. So thank you for this opportunity to share. I look forward to our questions and discussion.
Thank you so much, Dr. Fuentes-Afflick. Our first question today is, how does access to healthcare, preventative and interventional, and human services correlate with health outcomes?
Thank you. There's no question, we focus a lot on this in health professionals because this is our so-called wheelhouse. This is what we do. And I believe that there is evidence that preventive care and interventions do have an impact on both health outcomes and health disparities, but it's not as powerful, it's not quite as close a relationship as we might consider, in part because we know that patients, when they come to us, have a whole list of mitigating factors, some of which we can address and some of which we can't. At the General, we have created a program called Health Advocates, and we have a whole army of undergraduates, mostly from San Francisco State and UC Berkeley, who help us identify the social needs of our patients, and then they link them with resources to address those needs. And so we're evaluating the success of that program. It's based on a program founded in Boston, hoping that we can work in partnership so that we can really maximize the impact of our health services with our outcomes. But we know that we are only a part of the whole puzzle of improving outcomes.
Thank you. Our next question is, in your role at the National Academy of Medicine, what is your focus?
The Home Secretary is a role that focuses on membership. So I oversee the election process of members. I oversee the structure and design of our sections and our interest groups. I'm also responsible if there are allegations of misconduct raised against any of our members. And I am trying to increase engagement, both with our members, but we know that there are many people who participate in our programs as non-members. We have an emerging leaders program, which is fantastic, and I'm engaged with that. So it's really trying to enhance the vigor of our activities. I interact quite closely with my colleagues at the National Academy of Engineering and the National Academy of Sciences. We're all trying to have an impact on the important issues of our time, and we have incredible members, so I try to engage them in that process.
Our next question is, do you think that pediatric organizations are ready ready for change to meet the need to address social justice for children and families?
I hope so. I think there has been a lot of activity within, certainly if we think about the PAS family of organizations as the population we're talking about, just because those are colleagues, many of us belong to those organizations. I think there has been a push, both from the community as well as from our members. I mentioned to you the Committee on Diversity and Inclusion for the APS, but the Academy has activities in this area. The Society for Pediatric Research has activities, the APA. So I think we are at a point, I hope it's a tipping point, between the push from society and the push from our organizations where we can be working collaboratively to make meaningful change. So I think we're ready. And I think we have a special responsibility in pediatrics because we are the ones who interface with that next generation of children. We want them to achieve their potential, but we know that they need to be healthy, they need to have food, they need to have housing, they need to have stable families. We know how the pandemic has affected all of them. So I think our voice is especially important in the social justice movement because of our unique perspective.
Thank you so much. It's such a good point about the importance of collaboration to really create collective impact. Um, our next question is, what is your opinion of the use of the word Latinx? Um, our questioner understands that it's not always the accepted term, as it's not familiar or phonetic for the Spanish language.
This is something, for example, not with Dr. Lopez, who's going to be speaking with you next week, but with another collaborator. We've had a lot of discussions. I don't like it personally. I feel like it, as you said, like it's not, it's an adaptation to me of the term Latino. Now, as a Romance language, we know that we use the male form to be generic. And so that brings with its own inherent limitations. But to me, Latinx is to make it easier for the non-Latino community to use the term. Now, if it elevates conversation, if it makes it easier for people to be more inclusive, I can accept that, but personally, I don't like it.
Yeah, I completely understand that. The follow-up to that question is there's been a hope that Latina may gain more usage as you can pronounce it in Spanish in a way that's more neutral and is gender neutral. Is this something, in your opinion, that would kind of tackle that disconnect?
I think it could. I mean, I see some people using LATIN and then the ampersand to reflect, A and O to be the more generic. We just don't know how to pronounce that. I mean, it's not a pronounceable word really in Spanish. So I don't know what the right word, and maybe this is not really a uniquely American thing, but maybe we got to come up with something else that some people call Latine, right, with an E at the end, because then it's not the O or the A. But again, that's a bit of an invented term. So maybe we just have to come to terms with, we're going to have to create a new term and then just embrace it. I think we're at a little bit of a discussion point on that.
Yeah, I agree. The other question I have is, you talked about both DE&I and health equity, which are really important but separate concepts. How do you see the relationship between the two?
Well, in many ways, a focus on DEIA, if we include anti-racism, provides us, I think, a structural way to understand some complicated concepts. And you and I yesterday evening, Dr. Floyd, were talking about the different institutional approaches we've taken to train faculty, staff, and learners. How do we have a shared vocabulary so that we can identify problems, that we can have structures that will help us advance? So I think DEIA gives us a foundation, a framework to talk about things. Clearly, equity is the goal we are trying to reach, but I think we need to have ways to get to the goal. So that's how I see them playing together. And I hope that as particularly young people who are more comfortable both pushing limits, integrating concepts, will really accelerate our progress in that area. But part of it is also for health systems, for departments. We need to monitor, how are we doing with faculty diversity? How are we doing with inclusion, right? Because I love that expression, right? You can be invited to the party, but being asked to dance, difference between being there and being included. So we need to understand, how are we doing with all of those measures? We can't achieve equity without improvements all along the way.
That's such a really good point with that holistic approach and assuring that we have that foundation in order to have these conversations and to move our systems forward. Thank you so much for such a wonderful talk today. It's such a privilege to be able to introduce you and do the Q&A with you today.
Thank you so much. I'm honored. Really look forward to, there's a lot of history between our institutions, but we don't have to be limited by that. And I hope certainly under Dr. Leonard's leadership that we will have more opportunities within pediatrics to continue to collaborate. So I'm honored to have been invited. Thank you for your attention and wishing you a good rest of your day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.